Welcome to part 97 of this explainer series. I'm Harshal, and we are jumping right back into our Guidelines Masterclass with part 3. Today's mission is absolute precision. We are cracking those notoriously tricky Chapter 15 and 16 exam traps that literally eliminate unprepared CPC, CCS, and CIC test takers every single day. We're going to arm you with the exact logic you need to spot these traps from a mile away.
Here is the syllabus for today's masterclass. We're diffusing 4 massive traps: OB sequencing priority, the 080 normal delivery distractors, maternal versus newborn boundary rules, and finally, perinatal versus congenital guidelines.
All right, let's dive right into our first minefield. Trap number 1, OB sequencing priority. You know, the moment a patient is pregnant, the entire coding landscape just completely shifts, and test makers absolutely love to exploit this. Consider this classic board exam scenario. A pregnant patient at 32 weeks gestation presents with pre-existing hypertension. The big question is, what code belongs in that principal or first listed diagnosis slot? Now, under pressure, you're going to feel this massive psychological pull to grab I-10 for essential hypertension, right? Because clinically, that's what the patient has, and maybe you pair it with Z3A.32. Well, don't do it. That is a trap. The compliant answer here is the Chapter 15 complication code, O10.013, for pre-existing hypertension complicating pregnancy, followed by your Z code.
And this brilliantly illustrates the CMS guideline acting as our diffusal code. It explicitly states that Chapter 15 codes have sequencing priority over codes from other chapters. Essentially, Category O codes always override non-OB codes whenever a condition complicates a pregnancy. Unless the provider explicitly documents that a condition is completely incidental to the pregnancy, that O code takes slot number 1, period.
Let's move along to our next challenge. Trap number 2, the 080 delivery strict eligibility trap. We really need to unmask the highly tested, uncomplicated normal delivery code. Look, 080 is not a catch-all bucket. It has incredibly strict criteria. You can only assign it when the delivery is completely normal, full-term, a single live-born infant with 0 antepartum or postpartum complications, and absolutely no surgical intervention other than an episiotomy. So a low transverse C-section? Immediate disqualifier. So picture this. You see a board exam question documenting a perfectly healthy delivery where the mother simply sustains a minor first-degree perineal laceration. Do you take the bait and choose 080? I mean, a first-degree tear seems so normal and routine, right?
No way. Choosing 080 here is an immediate incorrect answer. You have to completely bypass the normal delivery code and assign the specific complication code 070.0 for the first-degree laceration, followed, of course, by Z37.0 for the outcome. According to the guidelines, the mere presence of that laceration means the delivery is no longer considered uncomplicated.
Okay, let's hit our third trap. Trap number 3, maternal versus newborn records.
What's really fascinating about this one is how it draws the ultimate boundary line in obstetric coding. You must treat the mother and the newborn as 2 entirely separate coding universes. Board exams love to use these crossover distractors to weed out unprepared test takers. Category Z37, which is outcome of delivery, belongs exclusively on the mother's record. Category Z38, for a live-born infant, belongs exclusively on the newborn's initial birth record. Mixing them up on an exam is an instant fail.
The official guidelines don't mince words here. They are undeniably clear on this absolute separation. Z38 is assigned only on the newborn record to tell the story of the birth from the baby's perspective. Z37 tells the outcome from the mother's perspective. Never, ever let those 2 cross over.
Finally, let's unpack trap number 4, perinatal and congenital rules.
Here, you've got to draw a hard line in the sand between chapters. The crucial point is to separate P codes from Chapter 16, which are for birth-acquired perinatal conditions, like a birth injury, from Q codes in Chapter 17, which represent structural congenital anomalies the baby was actually born with. Test makers will mix these up in the multiple choice options just to see if you're paying attention to your chapters.
But here is the absolute kicker, the prematurity sequencing trap. When a premature infant scenario documents both birth weight and gestational age, there is a strict hierarchy you must follow. Step 1 must be the birth weight code from category P07.0 or P07.1. That has to lead. Step 2 is then the gestational age code.
Look at this exact wording from the CMS guidelines. This proves exactly why birth weight priority in prematurity questions is a non-negotiable rule. It genuinely doesn't matter what order the physician dictated the notes in or what you think reads better clinically. The guidelines dictate that birth weight leads gestational age,
every single time.
So I have to ask you, when you're sitting there under the clock, feeling the pressure of the exam, will you let your own clinical intuition override these strict coding guidelines and fall right into the test maker's trap? The biggest takeaway from today's explainer is to prioritize official guidelines over what makes sense medically. By memorizing these strict boundaries, you make yourself immune to their distractors.
And that wraps up part 3 of our Board Exam Traps Masterclass. If you found this explainer helpful, make sure to like and subscribe so you don't miss our next installment. Join me next time for part 98, where we are going to completely conquer trauma 7th characters, fractures, and external causes. Keep your guidelines close, stay focused, and I'll see you in the next one.